Today's advances in understanding cancer biology are important for all of our patients, obviously also for the elderly patients, because we believe that by really addressing the mechanism that is underlying the cancer progression, we will avoid some of the side effects related to drugs which are not that specific. And therefore, for our elderly patients who are more fragile, we will decrease the risk of having side effects that would be deleterious for their outcome. Unfortunately, elderly patients are not often in all studies. There is still a trend, even if it is not official anymore, to not include elder patients because colleagues believe that they will not tolerate the treatment because of the comorbidities that comes with age. Elder patients not being in clinical trials as often as they should be means that we will not have the numbers needed to really evaluate what is the interaction between the agent used to treat the cancer, the other drug that the patient needs for the other diseases that they might have, and the elderly have other diseases, which can be considerably impacted by the interaction between the drugs, or also can impact on the tolerability of the treatment by the elderly person. In the past, we thought that the age limit was determinant. We have realized that this is completely wrong. What is important is to understand who the elderly person is. Geriatricians have told us that we have several types of instruments that can look at the elderly person, assess the elderly person's reserves in terms of, for example, diabetes, lung disease, cardiac disease, and then determine how frail this person is. And depending on the frailty level of the elderly person, we will have to adapt the treatment, or very often this frailty can be a reason for a specific geriatric intervention. Today's treatments tend to be more and more in the oral form, both cytotoxic agents as so-called targeted agents. I always laugh about that because hormonal treatment is a targeted agent and we never use targeted for hormonal treatments. The fact that they are long-term treatments means that we know the patient will start the treatment, and then the patient might experience some side effect and will decide, well, after all, I'm not going to take this, but I'm not going to tell the doctor either. So this can happen. Another thing that can also happen is that patients will tend to forget. This is an issue in elderly patients, and the management of these long-term treatments with oral therapy really needs a different type of approach. We cannot simply prescribe and see the patient a few weeks later to see what has happened. We have to have a way of communication, and depending on the country, depending on the setup of the health system, this can be either through the physician or through the nurse or through the local GP that can be involved in some countries, in order to make sure that the patient come back, ask the questions, and be encouraged to continue even if there are some initial side effects. Doctor-patient contact is of prime importance. The importance in the elderly person is the same as in the younger person. You have to have a bond between the doctor and not only the doctor, the whole treating team, the nursing team and the patient, because the faith that the patient will have in the outcome is very much dependent on the trust that the patient has in the team. And what I would like to emphasize for elderly patients is the importance of eliciting their opinion. Elderly patients tend to be less active in giving their opinion. They are a little bit more passive. This has been shown in studies. It is very important to allow them to say what they think, what is their goal besides our goal, and to match the two goals.